Imagine, being in just agonizing pain for like 4 years.
Oh, yeah. It's awful.
Like a deep, heavy ache in your pelvis that just ruins your day, ruins your sex life, and leaves you utterly exhausted.
Right.
But but every single time your doctor puts you on the exam table to find the cause, the physical evidence of your disease literally just vanishes into thin air.
It's crazy, but it happens all the time.
It really does, and that's the reality for up to 30% of women suffering from chronic pelvic pain. It's this condition characterized by a disappearing act. And today, we're going to expose exactly how it hides.
Yeah, it's honestly a cruel trick of human anatomy.
Definitely.
And it highlights this massive blind spot in modern diagnostics. We tend to compartmentalize the body so much, like you go to a gynecologist for pelvic pain
Right.
or a vascular surgeon for vein issues. But this condition falls right into the cracks between those disciplines. To really understand it, we have to stop looking at static images and start understanding the actual dynamic physics of the human body.
Exactly. So the condition we're talking about is called pelvic congestion syndrome, or PCS.
Mm-hmm.
And our stack of sources for today's mission, we're pulling from comprehensive medical journals on venous compliance, clinical FAQs, and the latest vascular surgery guidelines.
Some really dense stuff, but
Yeah.
so important.
Yeah, super dense. But we have a very specific goal today. We're going to find out if PCS can physically alter the vascular compliance of the vaginal walls and the surrounding pelvic region.
Right.
And crucially, we want to know if this specific vascular change is the hidden culprit behind a very frustrating, very misunderstood symptom, which is this dull, aching post-coital pain.
Yeah, that post-coital ache is a huge factor for these patients.
It is. So to help us connect all these anatomical dots, I've got our expert here to guide us through the literal pressure cooker of the human pelvis.
I am really looking forward to this one, because to grasp why this pain is so persistent and so hard to pin down, we first need to establish a baseline. We have to look at the sheer mechanical brilliance of how your circulatory system is supposed to manage gravity.
Right, because people usually think of their veins as like stiff, rigid pipes, like the copper plumbing in your house or something.
Exactly, which is so wrong.
Right. Based on these vascular journals, that analogy is completely off. They're more like, I don't know, dynamic bungee cords or these incredibly sensitive, high-capacity reservoirs.
Yep.
So why does the venous system need to be so flexible compared to the arteries?
Well, it all comes down to volume management.
Mm-hmm.
About 75% of all the blood in your body right now is just hanging out in your venous system.
Wait, really? 75%?
Yeah, 75%.
Wow.
The arteries, they do the high pressure work, jetting oxygenated blood away from the heart. But the veins, they're the storage facility and the return route.
That fundamentally changes how I picture the circulatory system.
Right.
If 3/4 of our blood is just sitting in the veins, they must be under an immense amount of strain.
They would be, yeah, if it weren't for this concept called vascular compliance.
Okay.
In physics, compliance basically refers to a structure's ability to yield to pressure or force without disrupting. For a vein, it means it can take on a massive influx of blood volume with almost zero increase in the internal pressure.
Oh, okay. So it's like a highly elastic duffel bag.
Yeah.
You can just keep throwing clothes into it, and the bag just stretches to accommodate them rather than the zipper, like, immediately bursting from the pressure.
That is a great way to visualize it.
Yeah.
And this is all possible because of the cellular architecture of the vein wall itself.
Okay. How so?
Well, the middle layer, the tunica media, is very different from an artery. An artery is thick with smooth muscle because it has to handle the rhythmic, high-pressure pounding of the heart.
Right, the pulsing.
Exactly.
Mm.
A vein has a much thinner media layer, but it's heavily laced with this very specific ratio of collagen and elastin.
Oh, elastin. So that's the stretchy part.
Yep. The collagen provides the ultimate scaffolding. So the vein doesn't just burst, while the elastin gives it that profound stretchiness.
That makes sense. And we mentioned gravity earlier. I imagine just standing up throws a major wrench into this whole volume management system.
Oh, absolutely. Think about the physical physics of just getting out of bed in the morning.
Okay.
The moment your feet hit the floor, gravity pulls downward. And almost instantly, 70% of your total blood volume drops below your diaphragm.
Oh, wow. Just a massive fluid shift straight toward the floor.
Yes. And your healthy veins use their elastin to simply balloon outward and accommodate that sudden drop in fluid.
Right.
But they also had a job to do, right? They have to get that blood back up to your heart. They have to fight gravity every single inch of the way.
Right, because veins don't have a pump.
Exactly. They don't have a strong pump like the heart driving them, so they rely on your skeletal muscles. When you walk, the muscles in your legs and your pelvis kind of squeeze the veins, pushing the blood upward.
Okay, but how does it not just fall right back down?
Well, to keep it from simply falling back down between steps, veins are equipped with these tiny, delicate one-way valves.
Oh, I've heard of these.
Yeah, they act like little pocket doors that just snap shut, locking the blood in place until the next muscle contraction pushes it higher.
Okay, let's unpack this. Veins are heavily laced with elastin, specifically so they can stretch, and their entire biological purpose is to handle these massive shifts in volume when we stand up. Then why is stretching out considered the main problem in pelvic congestion syndrome? Like, if they're built for this, how does a system so robust just permanently break down?
Yeah, and this is the crucial pivot from healthy function to pathology. Veins are designed to stretch, yes, but they're also designed to recoil.
Ah.
They have a biological elastic limit.
Yeah.
PCS, which, by the way, the medical community is increasingly calling pelvic venous disorders to kind of capture the broader scope of the disease.
Right.
It happens when that elastic limit is permanently breached. And those delicate one-way valves we talked about, they fail.
So the trapdoors snap off their hinges.
Essentially, yes. When the valves fail, you develop venous insufficiency. Gravity wins the tug-of-war. The blood flows backward, which is a process called reflux, and it just pools heavily in the absolute lowest point of the torso, which is the pelvic basin.
Keys. So what actually causes those valves to fail in the first place? Is it like a genetic defect, or is it trauma to the tissue, or what?
It's usually a compounding series of mechanical and chemical factors. The most significant mechanical factor is pregnancy.
Okay.
During gestation, a woman's body increases its overall blood volume, and the capacity of the pelvic veins specifically expands by a staggering 50% to support the growing uterus.
50% more capacity.
Yeah.
That is an unbelievable amount of sustained mechanical strain on those vessel walls for, what, 9 months?
Right. It pushes the collagen and elastin to their absolute limits. And for some women, after childbirth, those heavily stretched veins never fully revert to their original size.
Because they just stay stretched out.
Exactly. The walls remain permanently dilated, which means the two flaps of those internal valves, they can no longer meet in the middle. The doorway is just permanently stuck open.
Oh, man. So gravity is just constantly dragging blood back down into the pelvis because the physical seal is broken.
Exactly. And then we add a really powerful chemical factor to the mix. Hormones.
Oh, right.
Estrogen is a known venous dilator. It basically chemically signals the smooth muscle within the vein walls to relax.
Which would completely explain why our sources emphasize that PCS is almost exclusively diagnosed in premenopausal women.
Yes, exactly.
The continuous cycling of estrogen is just keeping those already damaged veins in a relaxed, dilated state.
That is the consensus, yeah. Once estrogen levels drop significantly after menopause, the vasodilation decreases, and the symptoms often naturally fade.
Fascinating.
But there is also this fascinating anatomical wildcard that the sources point out. Roughly 13 to 15% of the population is born completely missing the valves in their left ovarian vein.
Wait, really? Just congenitally absent?
Yep.
So before they ever even experience a pregnancy or hormonal shifts, they're starting with a severe structural disadvantage against gravity.
Exactly. So whether it's pregnancy, estrogen, or genetics, the end result is the same. Massive amounts of blood pooling in the pelvis.
Right.
This creates chronic pelvic venous hypertension. The veins are under constant, relentless high pressure. And here is where we actually answer your question about why the system breaks down.
All right.
To survive this chronic high pressure, the body attempts to adapt. It forces all that excess blood into collateral pathways, right? It spills over into the intricate web of veins surrounding the uterus, the ovaries, and the vaginal walls, which is the gonadal and pelvic venous plexuses.
Gotcha. So it's just trying to find any available detour for the traffic jam.
It does. But these smaller veins were never meant to hold that much volume, so they severely dilate. Over time, that constant hypertension forces the cells in the vessel wall to physically remodel themselves.
Remodel? Like,
Well, the body lays down thicker, stiffer collagen to prevent the vein from literally rupturing. But in doing so, the tissue loses its elastin. the physical architecture changes.
Oh, wow. So the adaptation actually destroys the very compliance that made the vein work in the first place.
Exactly.
It's like blowing up a balloon until the rubber gets really thin, leaving it inflated for a month, and then letting the air out. It never goes back to being a tight little piece of rubber.
Right. It's warps.
Yeah, it becomes this baggy, warped reservoir that has entirely lost its snap.
That is the precise mechanical failure, yeah. Because it has lost its elastic recoil, the vein is trapped at maximum capacity. It now has incredibly low compliance.
Okay.
So any new volume of blood entering that baggy vein cannot be gracefully absorbed by stretching. Instead, a new influx of volume causes the pressure inside that stiffened vessel to absolutely skyrocket.
Here's where it gets really interesting. Because now we understand the physical state of these damaged, non-compliant veins. But how does this mechanical breakdown translate into the specific physical pain we're investigating? Like, a patient goes to the doctor with a deep, aching pain in their vaginal walls after having sex.
Right.
Often they're told it's a muscular issue, like pelvic floor spasms, or they undergo surgeries for endometriosis only to find absolutely nothing. Tell us the hidden vascular truth behind this post-coital pain.
Well, when we connect this stiff, non-compliant vein to the nervous system, the mystery of the pain completely unravels.
Okay.
Because the veins have lost their compliance, any sudden influx of blood drastically spikes the internal pressure. This extreme sudden stretch, combined with the stagnant pooling of deoxygenated blood, it actually activates selective pain receptors that are embedded within the vessel walls themselves.
Wait, I need to pause there. The veins themselves are the source of the pain.
Yes.
They aren't just swelling up and accidentally bumping into a nearby pelvic nerve. They are actively generating the pain signal.
Yeah, the vessel walls are dense with no S-receptors pain receptors. But the mechanism goes even deeper. The severe mechanical stretching of these damaged vessels actually causes the endothelial cells lining the vein to become inflamed.
Really?
Yeah, they physically release pain-inducing neurotransmitters and inflammatory mediators directly into the surrounding pelvic tissue.
That is insane. The veins are literally sweating pain chemicals into the pelvis because they are so engorged and stressed. That is incredible.
It is a profound, localized inflammatory response.
Yeah.
Now, let's map this directly onto sexual intercourse.
Okay.
Sex involves significant physical exertion, right? Which raises the heart rate and blood pressure. But more importantly, sexual arousal involves a massive, concentrated rush of arterial blood flow directly into the pelvic region and the genital.
Right, of course.
And on top of that, orgasm triggers intense, sustained uterine contractions.
All of which is just driving an overwhelming wave of blood down into the pelvic basin.
Exactly. But remember the state of the infrastructure. The vascular compliance of the vaginal walls and the entire pelvic plexus is fundamentally altered.
Right. It's baggy.
It's baggy, it's stiff, and the valves are broken. So when that massive wave of arterial blood rushes in during arousal, the venous system cannot expand to absorb it, and it cannot effectively pump it back out.
Oh, man. It hits a brick wall, and the localized pressure spikes instantly.
Yep. The blood pools aggressively in the vaginal and pelvic tissues. And the result is a classic hallmark symptom of PCS. A dull, heavy, aching pain deep in the pelvis and vaginal walls, which is clinically referred to as dyspareunia.
Wow.
And unlike a standard muscle cramp that flushes out and fades relatively quickly, this blood is physically trapped by gravity and those broken valves.
Because it can't go anywhere.
Right. And because the veins continue to leak those inflammatory neurotransmitters, that heavy post-coital ache can linger for hours. Frequently, patients report the pain lasting entirely into the next day.
The psychological toll of that must be devastating.
Oh, absolutely.
To associate intimacy with a guaranteed 24-hour hangover of deep pelvic pain, and this vascular chaos, it doesn't just stay hidden deep inside the pelvis, does it? I mean, the sources mentioned this pressure can manifest visibly on the outside of the body.
Yeah, because the venous system is a highly interconnected network.
When the deep pelvic veins are overwhelmed, that extreme pressure searches for an outlet.
Right.
So it often backs up into the superficial veins just under the skin. Patients frequently develop visible varicose veins in the vulva, the perineum, and the upper thighs. It's a very clear visual clue to the hidden high-pressure environment inside the pelvis.
Okay, so this brings me to a massive contradiction in the literature.
Okay.
If the anatomy is this fundamentally altered, if we have veins that are visibly bulging, leaking neurotransmitters, and causing a profound, heavy ache that just ruins people's lives, why in the world do our sources state that it takes an average of 4 years for a patient to finally get a correct diagnosis?
It's a huge problem. How is the medical system missing veins that are so swollen they are creating their own inflammatory crisis?
The answer lies in the greatest diagnostic illusion in modern medicine, which is the exam table.
Oh, you're talking about gravity again.
Yes. Think about the standard protocol for diagnosing pelvic pain. A patient goes to a specialist. They lie down on an examination table in the supine position flat on their back for a manual pelvic exam.
Right.
They lie down flat for a transvaginal ultrasound. If the doctor suspects endometriosis, they undergo a diagnostic laparoscopy.
Which is surgery.
Yeah, a surgical camera is inserted into the abdomen while the patient is completely flat and anesthetized, and the abdomen is inflated with carbon dioxide gas to give the surgeon room to look around.
Oh, I see the trap. Because they're lying flat, gravity is no longer pulling the blood down into the pelvis. The mechanical load is totally gone.
Exactly. The moment the patient lies down, the blood effortlessly drains out of the pelvis and flows back toward the heart. Those massive, baggy, engorged veins completely empty out. They collapse. And they look like completely normal, healthy tissue. Add the pressure of the surgical gas during a laparoscopy, and those veins are flattened even further.
So when the radiologist looks at the ultrasound or the surgeon looks through the camera, the evidence has literally just vanished. The veins look fine.
It is the ultimate disappearing act. The doctor sees normal anatomy, rules out cysts or endometriosis, and the patient is told everything looks fine. Or, tragically, they're told the pain must be psychosomatic.
Ugh. Being told it's all in your head when your veins are structurally damaged and leaking inflammatory chemicals, that is maddening. So how do we catch the disappearing act? What's the diagnostic fix?
You have to change the physical parameters of the exam. You have to reintroduce gravity.
Okay.
The gold standard for diagnosing pelvic congestion syndrome is performing imaging, whether that's a specialized transvaginal ultrasound or a venogram where dye is injected into the veins, while the patient is either standing entirely upright or while they are performing the Valsalva maneuver.
The Valsalva maneuver, that's where you take a deep breath and bear down hard, right? Like forcing pressure into your abdomen.
Yes. Bearing down artificially spikes the intra-abdominal pressure, effectively mimicking the downward force of gravity and driving blood back down into the pelvis.
So you force the issue.
Right. When a radiologist observes the veins under those specific conditions, the faulty, non-compliant vessels suddenly balloon outward.
Wow.
They are specifically measuring the diameter of the veins, looking for anything wider than 6 millimeters. They also measure the velocity of the blood flow. If the flow is sluggish-like, dropping below 3 centimeters per second, or if they can actively see the blood flowing backward, the diagnosis is confirmed.
So what does this all mean? It is literally like trying to diagnose a flat tire while the car is jacked up on a hydraulic lift.
Exactly.
The tire looks perfectly round in the air. You have to take the car off the lift and put the heavy weight of the vehicle onto the tire to actually see where the structural failure is.
That is the perfect analogy. You have to load the system to see the system fail.
That makes so much sense. So once a patient finally gets a doctor to perform an upright ultrasound and they finally catch the diagnosis, what is the next step? Are they just stuck managing this altered compliance, or is there an actual fix?
No, there are highly effective fixes. On the medical side, doctors will often prescribe specific progestin-only medications.
Okay, why progestin?
Well, progestin counteracts estrogen. By suppressing the estrogen levels, you remove that powerful chemical vasodilator, which allows the smooth muscle in the vein walls to contract and reduces the pooling.
Oh, nice.
It's often a great temporary measure. But the definitive long-term solution is structural.
Fixing the broken plumbing.
Exactly. Interventional radiologists perform a minimally invasive procedure called endovascular embolization.
Embolization, okay.
Using image guidance, they insert a tiny catheter into a vein in the neck or the groin and thread it all the way down into the faulty pelvic veins. Once they locate the specific veins that are refluxing, they deploy tiny metal coils, or they inject a specialized medical foam called a sclerosant.
Wait, what does the foam do?
The foam acts as an irritant. It deliberately damages the endothelial lining of that broken vein, causing it to instantly scar shut.
Wow.
The coils do the same thing, providing a physical barrier that the body forms a clot around. They permanently close off the bad highways.
But doesn't the blood still need to get out of the pelvis? If you block the veins, where does it go?
Well, the human body is remarkably adaptable. Once the damaged refluxing veins are closed, the blood simply reroutes itself to adjacent, healthy veins that still have their elasticity and functioning valves.
The collateral pathways that actually work?
Yes. Now, the sources also highlight that sometimes the root cause isn't just a broken valve in the pelvis, it's a major compression issue higher up in the abdomen. And that requires a totally different approach.
Oh, like the compressive syndromes mentioned in the vascular guidelines, like Nutcracker and May-Thurner.
Exactly. Let's look at Nutcracker syndrome. It happens when the left renal vein, which drains the left kidney, gets physically pinched between the massive abdominal aorta and another major artery.
So it's pinched.
It is literally squeezed like a nut in a nutcracker. Because the left ovarian vein connects to the left renal vein, that pinch creates a massive traffic jam. The high pressure cascades all the way down into the pelvis, causing PCS.
Jeez.
And May-Thurner syndrome is a similar mechanical pinch on the right side, where the right iliac artery compresses the left iliac vein against the spine.
So the pelvic veins are ballooning out because a major highway upstream is completely blocked.
Yep.
How do they fix a pinch like that? I mean, embolizing the vein wouldn't solve the structural crush.
No, it wouldn't. In those cases, vascular surgeons go in and place a sturdy metallic stent inside the pinched vein. The stent acts as an internal scaffold, forcing the vessel open against the crushing weight of the artery.
Oh, that's brilliant.
The moment that stent is deployed, the traffic jam clears, the pressure drops downstream, and the pelvic congestion resolves.
That is incredible. To take someone from 4 years of invisible, unexplained, chronic agony to a minimally invasive procedure that simply redirects traffic or props open a pinched highway, it just completely removes the mechanical failure.
The outcomes are exceptional, really, for patients who finally get access to the right diagnostic imaging.
Let's bring this all together. We started with a mission to understand the hidden mechanism behind a very specific, deeply frustrating kind of post-coital pain. And we learned about the physics of venous compliance, how our veins are engineered with elastin to be dynamic shock absorbers for gravity. We saw how the massive mechanical strain of pregnancy, combined with the chemical relaxation of estrogen, can permanently stretch out the pelvic veins, destroying their delicate one-way valves.
And we discovered that the body's attempt to reinforce those overstretched veins actually destroys their compliance. They become these stiff, baggy reservoirs that completely fail when faced with the sudden influx of blood during physical exertion and sexual intercourse.
Right, and that localized spike in pressure triggers pain receptors embedded right in the vessel walls, causing the veins to literally sweat inflammatory neurotransmitters into the pelvis.
Exactly.
This creates that agonizing, heavy ache that can linger for a whole day. And the only way to prove it's happening, to overcome the medical gaslighting of a collapsed vein, is to force gravity back into the diagnostic equation with an upright or Valsalva ultrasound.
The takeaway for anyone listening is just how empowering it is to understand the actual physics of your own body.
Absolutely.
When you know how a system is supposed to work and the specific mechanics of how it fails, you become a formidable advocate for your own health. If you're dealing with chronic, invisible pain that miraculously disappears when you lie down in a doctor's office, you now have the vocabulary to say, the mechanics of my pain are triggered by gravity. I need an ultrasound while I'm standing up.
Knowledge truly is the best diagnostic tool we have. But before we wrap up today, I want to leave you with a final thought to chew on. We've talked extensively about how gravity is the absolute nemesis of the venous system, right? Constantly dragging blood down and overwhelming these delicate pelvic valves. It kind of makes me wonder about the future of our species. Since gravity is the root mechanical stressor causing these valves to fail, how might human evolution adapt our vascular architecture over the next 10 or 20,000 years?
That's a great question.
Or, taking it even further, if humanity ever achieves the prospect of living in a low-gravity environment, like a colony on Mars or the Moon, would that fundamentally alter our circulatory physics? Without Earth's heavy gravity constantly dragging on our blood volume, would pelvic congestion syndrome simply cease to exist entirely?
Oh, wow. It's a brilliant thought experiment. The baseline physics of the human body would absolutely have to remodel itself to survive a new gravitational reality.
It's definitely something to mull over the next time you stand up, feel the blood drop, and realize just how hard your body is working against the physics of the planet. Thank you for joining us on this deep dive into the hidden mechanics of chronic pain. Keep questioning the consensus, keep seeking out the why behind the what, and never stop exploring. We'll catch you on the next deep dive.